do have a little bit of catching up to do, and we'll do that with the presentation from the first pre-lunch session, which is another case of a problem resident, which will be presented by Dr. Apurva Ayachid from MM Joshi Eye Hospital, Eye Institute in Hubli. If we can have an introductory slide uploaded.
And I'm just going to take a second to welcome Dr. Padmalini from Narayan Nethralaya onto the panel. So thank you. We are running late. I know you arrived well ahead of time. So please do, pitch in and share your experience.
Shall I start? Yeah. Okay. So the problem resident I had in mind was something I'm facing right now as we speak. Back home, there are some residents like this. So these are real life experiences, could be one or more than one resident like this. So I've called my presentation the problem resident, the one who needs to be taught from scratch each time, every time. So there are knowledge hungry residents who have extraordinary retention. They extrapolate concepts taught in lectures to other case scenarios. They observe very keenly, and while assisting, also when they are doing the surgery, they require little to no help. And they proactively present and write papers and offer to help also for ongoing projects or take on new ones. So this resident is in second year, for example. So there is OPD clinic going on, and the consultant can be me. So I tell the resident, you've seen this case and you've said there is aphakia, but there is an IOL in the sulcus. Please look carefully next time. So the resident says, yes, ma'am. The next week, again, this resident, if he's posted with me, if he or she, so I say, you've written IOL in sulcus in your notes, but there is an iris claw lens. You've seen iris claw lenses before, haven't you? And the resident says, yes, ma'am, I have seen. I will look more closely here on. And they're like, okay, I'll look at it. 1 month later, you've noted the lens status as pseudophakia, but the patient is aphakic. Could you please spend a few more seconds on the slit lamp? You keep making mistakes like this. Lens status is very important for management of any ocular condition. Can you not please make the same mistake again and again? This time, there's just a nod. Then 3 months later, there is an IOL, that's what they have written. IOL is subluxated inferotemporally, but when I see it is inferonasal subluxation, I say, you've noted subluxation wrong. Now they just avoid my gaze. They just face me with silence and start walking away. So the general behavior of this resident or residents are that they usually keep silent in lecture halls, and when asked a question, they stall. They know we will move on to another person. And they don't assist very well. They keep being told to irrigate or to retract something or pass instruments, and they seem distracted for the crucial steps. Like when you're doing a crucial step, they kind of don't seem to be paying attention. Also, they demonstrate almost disregard for our methods. They have their own new way of doing it, as if you've never seen seniors doing that step. And they do this again and again and again. So my special effort for such a resident is, for example, I ask them what is scleral buckling. They say, we put a 240 belt, pars plana vitrectomy. I'm like, what? And there is silence. And then I say, okay, read about buckling, write the steps, we'll discuss tomorrow. Read, say, Payman or some standard textbook, watch a few videos, so it will get cemented. Then they'll say, yes, very good. They're just glad to have gotten off the hook at that moment. Next day, unfortunately, they are posted in my OPD, and they look nervous. No prizes for guessing why. We go about the day, and the end of OPD, I ask, did you read about buckling? They say, no, ma'am. Then I say, why? Because I was reading for cornea class. And then I would say it would take you 15 minutes to read something like on iWiki, or you could have just watched a couple of videos to just come and start a conversation about buckling. So when will you read? I'll read. Next week, in the OPD, young phakic patient with detachment. They'll write some plan like vitrectomy and silicone oil, just basing it off some random knowledge they have gained just by being around retina people. Then I say a young phakic patient needs to be buckled. That is the key word, buckling. I even told you to read about it. They say, okay. So now my efforts in this direction, and I would like others' opinion on this, I probe. So what do you do when you get home? And they like, I get home by 8:45 in community postings. Then I say, but you're in retina since a month, you get off at 7 p.m. Then they'll say, yes, but I'm preparing for a seminar. But that seminar is 6 weeks away. I say it only takes 30-40 minutes to read a topic. At least the basics can be read from AIO series easily. Then they say I get tired, my family has come, I was on iCall, I don't have those books. And then my more sustained efforts. So I immediately send an e-copy of the books, tell them to go to the classroom in the middle of the OPD. I say take 30 minutes, read scleral buckling from a source of your choice, come back, make a few bullet points and tell me what you know. And they do it. And we happily discuss buckling for the next 20 minutes. But a few weeks later, in class, during a case presentation of retinal detachment, problem resident will, now I say randomly that problem resident will tell us about the management of this case, because I'm so confident that we've spent so many days and minutes of deliberating about why they didn't read, and finally you gave them time to read and they did. And now you're very confident that they'll be able to rattle off about scleral buckling. But then they stall and then, ma'am, and they keep staring at the screen. And then, but I say, you read this just a few weeks ago, we discussed this. So what I have surmised is that they're a little nonchalant, they're not invested in the residency, emotionally also. It requires a lot of emotional quotient to be invested in residency, to be invested in learning. And for some reason they feel like they just have to pass the exam, and for that some reading at the end is enough. They seem unaffected by questions asked to them about the subject, and they seem unaffected by their inability to answer also, or getting told the same things repeatedly. Is it poor retention? Is it low interest? They're definitely not unintelligent. So the same about surgery. They get stuck on the same step every time. They get told to assist well on the same steps. So my question to everybody is, how do you manage this problem resident?
Is this a fellow, post-PG or a resident?
So this is a fellow in mind, but the same can be said about residents as well.
What I feel is he is a resident and probably he was willing to have surgery or medicine or something else and has come in ophthalmology without choice.
Yeah.
He was forced into ophthalmology.
You're right. I always say this, many students, they get ophthalmology. They don't take or they don't choose ophthalmology, they get ophthalmology after counseling. You know what I mean. It's like they didn't get medicine, surgery or OBG. So they get ophthalmology. So that kind of, I think the entry level students are the average, according to the PG entrance test, they are average, the entry level students. I don't know, I mean, I surely cannot make a generalization, but.
Yeah, so Dr.
No, I think one of the other thing that I don't know whether you did it or not, but in the second instance itself, these kind of problematic residents require a frank conversation in a kind of a safe environment. Many times, I think there are other factors which are contributing to the poor attention. The second is that I think they have to be told in no unclear terms that a good clinical examination is must. And if they are not doing, we should not ask them to examine patients. And they can be taken through a retraining as far as the the slit lamp examination is concerned. And, third is that I think there should be some goal setting that have to be done in consultation with them, because they cannot be treated on the same line as the well-performing. Otherwise, they will constantly lag behind. Their goals have to be set based on their competency, not as per the other. These are three important things, because you might give them one exercise, they may do it, but the problem is somewhere else. And we need to probe deeper into what are the circumstances in which they are working. And one of the cause could be what he just narrated, that they are not interested in. And then if they are not interested, they can be told that they probably have no place in this residency program as well.
Excellent points, Dr. Prashant. And I was just going to add, I go as visiting professor to Ramchandra University. So, and I have committed to doing the OCEX for all the residents. So the last one, which I did about 2 weeks ago, so his confrontation fields was more like doing some Bharatanatyam dance. I said, I have sent you a video of how to do fields. And I looked at my WhatsApp, because we have a group there. And I said, 23rd November. Did you even watch it? He said, no.
Exactly.
I have not watched it. So, but otherwise, he's a very obedient resident, well behaved, very respectful, very good with the patients. So I just stopped the examination, had him sit down, and then said, I can tell you've just not been reading. You've not bothered to study at all. What is the problem? Is it because and I know he got married only, 7 or 8 months back, and his wife is in another center. I said, are you missing your wife? Is it? And then he just opened up. Like you said, you need to have a frank conversation which is not confrontational.
Yeah.
I said, you can tell me, I'm here to help you. So, and then he opened up and said how, he and his wife, they talk for hours together. And then his parents don't live here either. Then he talks to them, and then finally when he opens the book, he says he just is tired and he's just overwhelmed every single time. At Shankara Nethralaya, what worked in this type of scenario is to appoint a mentor for other than a goal setting, because you cannot take care of everybody.
Right.
It also depends on the size of the program. You could appoint either a junior faculty or a fellow as a mentor for the struggling resident, and set goals and timelines, make them all noted down. We are going to revisit this in 1 month. Put it in your calendar and be serious about it. So they know you're not just doing this, going through the motion. I think something like that might help.
Very good points.
Inherently in India, we are fearful or at least aware of exams. So periodic structured assessments can be one tool that may motivate them to study. So I remember at SN we had monthly exams, and even at LVP during fellowship we had open book exams, and so whatever it is, forcefully we would end up reading something. So.
But I think the kind of candidate that we are dealing with require a lot more of psychological help rather than a fear factor. And at times such residents, if you threaten them or make them more afraid of, may break completely, and there may be underlying psychological or medical causes that are resulting in poor performance. Therefore, I think if you consistently see the resident not making a correct judgment on the very simple, straightforward thing, it requires a very serious discussion to explore the underlying cause.
It always reflects that there is something deeper going on. It's not just lack of interest or lack of knowledge, or it's something deeper. By the time they become a fellow, especially, they have been through enough of the grind to know that there's no point in going through the motions.
Right.
And fellowship is something they join willingly. Usually.
Exactly.
Right? So yeah, it might just need a frank conversation and some help. We've had residents and fellows whom we've had to send to the psychiatrist, actually.
No, so have
Yeah.
we. So some of them came up with, I have insomnia, I'm not able to sleep, I just can't sleep, so I'm always a little preoccupied and stuff. And one more person I found out had lost a family member recently. So yes, those things do happen. But some of them are just nonchalant, even if you sit and talk to them, and it doesn't seem to make any dent.
What they want, only that particular thing they'll do well. Other things, it doesn't matter to them. They may not pay attention. I face the difficulty when the retina fellow posted and they want only, and UBA they try to neglect. And when they move out, then they have a query and they'll send the case scenario, what's up, my inbox will be filled. So in that way, what I tell them is first I'll try to counsel them, what the problem they have, try to address that at one-to-one and in a confidential way, so that whatever it will not be discussed. And the second thing is to make it interesting. So I encourage them what the positive aspects than putting it down. That seems to work well for them to do more.
So I think with that very interactive discussion, we move on to the next session, which is the session on is your trainee on track? And I thought Apurva's case fit in well with this theme as well. So it was a good segue. Our panelists will be, of course, Dr. Helena, Dr. Padma Malini, Dr. Rolika is here, and Pranesh, Dr. Prashant Garg, and Dr. Deepak Mishra. See here, I think he must be on his way. So our, in the interest of a little, to make sure that we do hear Dr. Prashant on time, he has a flight a little later in the evening. So we'll have his talk first, which is 360-degree evaluation of your trainee. And once, I think we can have a small discussion after his talk, and then we move on to the rest. उनका ये सेशन में थर्ड टॉक.
Okay, it's seen here, it's not seen on the screen. Okay, so thank you, good afternoon everyone, and I really want to thank Akshay for accommodating my request. The objectives of this talk will be to talk about why 360-degree assessment is important, to give you idea about how we conduct a 360-degree assessment, what are the key competencies that are typically evaluated as part of 360-degree, and how can we implement it in our setup. I think let me give you some case scenario. We are all aware of our residents or fellows who do very well in theoretical exams. They always will score very high. And if you look at those scores only, you will feel he or she must be a very bright candidate. The question is that how successful that tool is as an assessment is one of the questions that I have. Similarly, we have seen in a classroom there are candidates who just keep on raising hand, replying all the questions. Again, probably a trait that we consider that a resident is very good. Third is the residents who present themselves very well. They are not only well dressed, they have all the soft skills that are required to be a good doctor, and in the morning session we learned some of those soft skills. But are all these traits indicative of that a resident or a fellow will be a good doctor or clinician? Let us look at the case of a resident who was kind of extremely well behaved, very well groomed. But if you talk to the nurse will say he never comes on call when he is on call. And your phone is always switched off, we have to call repeatedly. Let us look at the scenario of the boy who kept on raising hand, answering all the questions, and you find that the colleagues complaining that he or she is rude, never allow us to speak, and he shouts at other colleagues of the. Third, a candidate who scored very well, and we have seen that in practice, that they are not so polite with the patients. Many times they do not even attend to the basic questions and the basic issues that they should be attending. Many times we struggle with such fellows not doing pre-operative rounds, or not answering the queries of the patient. Now, if we all look around, these situations are not uncommon. When you feel that a candidate is doing very well, but if you take feedback from others, you find that they are not. And therefore, I think one of the traits that is important for all of us to realize as a clinicians is that the clinical outcomes and the quality of clinical care does not entirely depends upon physician's performance. It also depends on how well you coordinate and collaborate with all other team members, right from how you behave with your front desk staff, to counselors, to your nursing assistant, to patient care staff. Everybody is part of the overall experience that patient gain. And your physician's quality alone are not the determining factor. Number two, that physician's knowledge is playing only small part. In clinical medicine, there are many other attributes that give comfort to our patient. How involved we feel with the well-being of the patient. And the words that, no, we will do our level best can make a whole lot of difference in the lives of people who are suffering with critical. So some of the competency domains that are very, very crucial in healthcare are mutual respect and shared values, understanding the roles and responsibilities of other professionals, communicate in a manner that supports the team approach, and truly a teamwork, which is involving relationship building, values, and principles. And therefore, you will all realize that our assessment of one time on their knowledge cannot provide a complete assessment of how good a clinician is. 360-degree assessment is a measurement tool completed by multiple people in an individual's sphere of influence. That is a typical definition of 360-degree assessment. And these assess competencies as well as behavior rather than the knowledge and personality. So it is important that those people are now going to give you feedback on the competencies. Now, what are the competencies that we need to assess? Besides knowledge base and skill proficiencies, on which we have talked a lot in the past 3 hours, we also need to know professionalism. We need to understand the ethical behavior. We also need to know about their capability as a team personnel as well as interpersonal skill, communication skills, and the use of information technology, because now information technology is playing another important role. It should also give you information about how good he or she is in facilitating learning of other team members. Now but the 3 important traits that are particularly crucial are the professionalism, team player or interpersonal skills, and the communication skills. So how do we implement these 360-degree assessment? The step 1 is, let us all be convinced about that 360-degree assessment provide you much wider overview of the trainee rather than their knowledge base alone. You need to decide and get buying in from other members, because if they are not made part of that decision, they may do shoddy job while they are providing you feedback on their performance of the trainee. So you should call all the members who are going to be part of 360-degree assessment and assess whether they are buying in on that idea or not. You should develop and adopt the existing tools that are already available. Some of these are published by the Ophthalmology Foundation. This is one tool that we published in Canadian Journal of Ophthalmology, how we conduct the 360-degree assessment. Interpersonal skill and communication skill, the attributes that you are going to be evaluating are effective communication with the patient and family, effective and respectful communication with the members of healthcare team, and use of effective listening skills, because they are the key attributes. And the question can be: resident communicates effectively while maintaining appropriate boundaries with the patient and families. Resident explains timely and effectively the process and course of action to the team. And resident elicit history using effective questioning and takes time and effort to explain the disease and intervention that are going to be on the patient. So there are other components also which we published in that journal. Now here, once you have identified what are the attributes, you can put questions in a manner that the responder is able to answer on a grid of 0 to 1, or agree, slightly agree, neutral, slightly disagree, or strongly disagree. Ultimately, you want to get insight from them on various traits that are listed here. Now, it is also important to educate all the stakeholders, because if you do not educate the stakeholder, again you will face the problem. We in LV Prasad Eye Institute once decided to carry out without educating stakeholder. And based on their own personal experience, without using any matrix, they have started giving 5 out of 5. And when we asked question as to what are the questions that you asked resident, they said, no, I didn't talk to the resident. What are the attributes that you looked into? No, he does very well. So what I'm saying is that the whole purpose of 360-degree assessment is lost unless you educate them. These are the attributes, these are the behaviors which are expected, and these are the behaviors which are unexpected. Now you use this on a grid to identify whether the resident has or demonstrate those attributes or not. Stakeholders, you will have to take faculty members, administrative staff, fellow resident, medical student. So all the people who are going to be in the sphere of the concerned person have to be made part of the stakeholders. You should also inculcate team training, make the residents and fellows or the program such that there is a sense that healthcare is a team effort, not an individual effort, and you should have some courses where other members of the team are also part of. So to conclude, while most of the assessments are done based on the knowledge base of a candidate, I think effective patient management is beyond that, and there are various other attributes that also we need to assess. And the 360-degree feedback is to ensure that we are looking at all other attributes so that ultimately the clinical care provided to a patient is of a desired standard. Thank you very much for your time.
I'm aware this is done routinely in LV Prasad, is what I
We did that.
okay. Anybody else has experience with implementing 360-degree? Dr. Helena, do you want to comment? Anybody else? And what, or for experienced educators, say like Dr. Padmal, what do you think is the success you will of implementing, or what are the barriers to implementing a 360-degree evaluation? What is your take? I mean, it's a big training center, Narayanatralaya. So what is your take?
We have independent modules, each one takes care of each aspects. So now everything put together to form the circle, which we need to do that.
So, I think when I joined my fellowship, we had a system that even my reports were given to Dr. Rao at that point of time by nurse in charge, by the what you call as a senior fellows, as well as my colleagues, the front desk staff and the operating nurse. And yes, and that's how actually I learned
Full
that.
thing.
So yes, it was not very structured on particularly but later on we brought that structure that you have to look at following trait. But he put that system long ago where he will say, is the fellow coming to the ward in the night for pre and post-op rounds. How is his behavior? Does he speak well? How he speaks to the patient and how he speaks to all of you. So these were the questions that he used to ask to every member of the team. And then only he used to give that assessment to us. And that he used that criteria to decide who is going to be faculty in his team or not.
So that's Dr. Rao, right? What do you think, Akshay?
I think a couple of points. As residents, we may not necessarily get the opportunity to do a 360-degree assessment before enrollment. But I remember as fellows that used to happen. There was in LVP, of course, residents are allotted through the nationwide NEET, but fellows are interviewed, and there's an MCQ, a multiple choice question exam that is like a screening, and then you go into an interview, which is the subject interview with faculty, and then there's a third interview with people who are not at all of the faculty. I remember that time Dr. GC, yourself, and Dr. Tara Prasad Das discussed absolutely abstract things, and what are you doing? How was your experience at this in your residency? What did you do different there? And what are your goals and plans? So I think in some way that was kind of a screening to see, is this guy going to fit in, or at least does he fit in with the expected goals and the visions of the institute? So
yeah, but that is I still will say that's a part of the 360 degree, because we are looking at other attributes of a selection as a fellow. But when you are there undergoing training, participating in different activities, if you take feedback from the different groups who are working with you, you get very good idea about what are the other attributes other than the knowledge that a candidate demonstrate while delivering clinical care. And that is more important.
When he asked you about residency, I hope you said good things.
No, and even about residency, since we're talking about flipped classroom, while we're doing a 360 assessment of the trainee, when Dr. Meenakshi was the academic director, she did a flipped 360-degree assessment of the trainers. So each trainee who would be posted with, each resident would be posted with a consultant for a month, had a rubric which included interpersonal skills, discussion with the patient, teaching, surgical skills, and exactly how you would have of the resident for the teacher, for the trainee, for the consultant, which would be confidentially, we had to come and give it to her in the back. So
No,
I think it works both ways.
360-degree feedback is not just for resident. It works other way around also, because you are playing role of being educator when you are educating, and therefore feedback from them has to come.
Yes, Dr. Akshay said for DNBs, we don't have, they come through the counseling. This applies to the fellows in the interview board, in addition to the mark sheets and other things, like from the HR team, the emotional assessment quotient is also assessed by the common person, and then they have an induction course. Behavior and other things have been taught to them by the administrative staff, and there the behavior is assessed not only by the consultant, the front desk, and the patient's feedback. All this is analyzed, and when they change the posting from one person to the others, everything is assessment to both, as well as the theory, the clinical aspects, and then the feedback is given, and then they change the postings.
Well, from the trainee point of view, I'll just add one point. We're kind of aware that everybody is observing us. Like, you know, I one day was told by Dr. Now that you're supposed to do this particular surgery. And I'm like, how do you trust me? Because you've never seen my surgeries. And that's the day when I realized that, no, he has technically seen my surgeries through everybody else. And somewhere it does give you a sense of fulfillment. It's like a tick mark. Okay, check mark. Okay, fine. Okay, it's a confidence level check that, okay, I'm doing something right, that's why this is being handed over to me. So from a trainee's point of view, the 360-degree assessment helps us also to build confidence further.
Thank you, Dr. Prashant.
Thank you. And I think with that, we move on to our second speaker in the session, which is Dr. Kaushik Murli. He'll be speaking on workplace assessment and application in the clinic. I think it's it straddles a little bit of what Dr. Prashant must have spoken.
Again, a personal note of thanks once again for accepting the talk. Literally less than 24 hours to go. Thank you.
So again, my talk is going to have two objectives. One is to cover what work-based assessments mean and how to actually apply it in the clinic. Again, I'd like to acknowledge Dr. Meenakshi for sharing some of her slides, some material that I've incorporated as a part of this presentation. So when you look at workplace-based assessment, the definition says that it is the assessment of the trainee's professional skills and attitude, and it should provide evidence of everyday clinical competence. So when you look at the definition, there are two words that are not necessarily highlighted, but when you want to actually implement it, becomes critical. One is to understand what does competence mean. Second is what is assessment. We've spoken a lot about assessment through the day. Competence has been defined by Dr. Karl Golnick in his paper as the ability to do something well. Now again, that is kind of vague, but I think over a period of time, it does stand out whether that competence is there or not there. Assessment again is judgment about knowledge, practical skill, attitude, and behavior, but you need do this against a known standard. When we look at workplace-based assessment and when we're looking at the newer modalities of training and teaching, there are again two aspects of assessment that typically happens. This again happens innately in our households, where we kind of assess our children or our children assess us, as well as in a school environment or at the workplace. So one is a formative assessment where the feedback is part of the personal learning and professional development. The summative assessment is like a movement to the next stage in their life or next stage in their career. So there the decision is about moving them up and progressing them. Now let's go back to the time when each one of us was a student. From school through college, medical school, postgrad, fellowship, some of us have been brave to take some more exams, but invariably these exams have been a high-stake kind of a event where you receive a grade, you're judged on that particular day that you have passed or that you're a failure. The consequences again can be varied. It can be either embarrassing because you thought you were a brilliant student but you did not stand up on that day, to possibly a derailment of your career, especially if you're looking at a fellowship entrance where it puts you off by a year. And here there is no question of you asking the assessors, especially in a situation like a DNB exam or an MS exam where you have no clue what marks have been awarded to you. So there is no feedback, there is no way you know where you've gone wrong or where you can improve. From here we are now talking about a workplace-based assessment, which is actually looking at something that's happening in your workplace and looking at your clinical competence, not necessarily giving you marks in terms of what your knowledge is, like the last slide Dr. Prashant shared, which is very apt in that we are not looking at knowledge, but actually looking at how you're applying that knowledge largely here. So all of us are part of some teaching program, and if we had to ideally structure it, like has been shared by Padma Malini ma'am, you would have an induction program where you're kind of setting context as to what the trainee can expect during the tenure of that program. Then there is some systematic teaching that happens. There is a framework that is there, there is a schedule that is there, and this teaching, the topics or whatever is being taught is based on a particular curriculum. In between is an area that possibly we sometimes miss, is of the workplace-based learning and assessment. That becomes very, very critical because that then allows you to make sure that you're giving an ongoing feedback back to the trainee and also receive feedback as to whether your training program itself needs to be tweaked. Because often we are teaching our students the way we were taught. Possibly they need a different way of being told what they need to learn or how they need to learn. So this kind of works both ways. And this allows a holistic approach and is a lifelong kind of a learning that you tend to then imbibe as a part of it. Now, this is a given saying that this is something that needs to happen. Then why is there a need to actually formalize this whole thing? First and foremost, a lot of our clinical colleagues are not good at observing clinical skills. They're brilliant clinicians, but they are horrible as teachers. So it is not a given that every good clinician is a teacher. The vice versa is usually true. At the same time, they document certain things which may have happened, or they may also carry forward biases of previous incidents with that same student. So generalisms of saying you're always like this, you never turn up on time, you're most undependable, these kind of generalisms kind of creep into play. And sometimes, again, it flips to the other side where some of our colleagues are extremely gracious in giving an immense benefit of doubt, saying that, oh, possibly they are overworked, poor things, they don't know how to handle stress. They can't handle stress, probably they should not be in this profession. It's a given that we are handling somebody's life and eyes. So some amount of tension is part of what we've signed up for. And people always don't like to be the bad apple, so they want to be always good or known to be the good person, so they don't like giving feedback. And we have huge egos. As teachers, trainers, doctors, we don't want to be told we are wrong, because we know what we are doing, and that again kind of comes back to it. Again, I think Apurva through her problem resident did share, saying that we may love to teach, that doesn't mean that the other person is learning. So to assess that, a rubric or some kind of a metric becomes again very important to gauge as to where that person is. Now let's look at this 4-box thing where a person is either consciously competent, which is great, they know that they're very good, or they're unconscious about their competence in that they lack self-confidence and they otherwise are very good. They always think that they have much more to do. Other end, they are unconscious about their incompetence and that they have no clue what they are. They are gloriously ignorant and they are blissful in their existence. And the last bit is they're very conscious they're incompetent, like we shared earlier about somebody being thrust into a program that they possibly don't want to learn. Now, does a workplace assessment actually have a role play in this? Now, if you go back to how we defined it, work-based assessments facilitates us to observe a student, give them structured feedback in real-time clinical settings, and we believe that there is a possibility of improvement. So we go back to that same grid, we go back to the person who is consciously competent, asking them saying, what do you think you did well? To somebody who is consciously incompetent, asking them saying, what do you think you could improve? Or somebody who is unconscious about their incompetency, you be gracious and tell them saying, I think you can actually improve if you did 1, 2, 3, 4, 5. And who's unconscious and competent, you bump up their confidence by telling them saying, I think you are very good at this. So that way this workplace assessment allows you to kind of go back to that student and go back to where they are. What are the tools that we have in play? Now you'll see a whole lot of abbreviations here. They look extremely complex, but actually they're very simple. So OCEX is the ophthalmic clinical evaluation exercise. DOPS is the direct observation of procedural skills. The mini CEX is again, sorry, apologize for that. It is again a mini clinical evaluation exercise. CBD is case-based discussion. OSCAR is how you look at the surgical competency. And MSF is what Dr. Prashant presented just now, which is the 360-degree feedback mechanism. Now, a student who walks into our system has different layers that he has to go up before they achieve a level of competency. And based on how they enter in, initially you may have to look at only their knowledge because they may not be competent. They have no clue what they're supposed to do. To end of the training program where you're largely looking at how they're actually functioning in their work-based scenario. There you are not interested in how much of theory they know or the science they know, but larger how they are dealing with their patients in a real world. Now let's start off with the OCEX. This is actually one of the most comprehensive tools. There is enough published literature available about it. Here the resident looks at a new patient with the evaluator sitting in the room. They rate the resident and the feedback is immediate. So those are the most critical aspects of this. Again, this gets broken down into multiple layers, right from how they introduce themselves to how they elicit the history to how they look at the medication list. You can judge them into being a novice, a beginner, or a competent, or that particular line may be not applicable to that patient. What do I mean by that? A person with conjunctivitis, possibly they don't need to do a confrontation field. So you can't say that, oh, he's a novice, he didn't do the confrontation field properly. So for that line item, you will put it as not applicable. Therefore, that examination varies to that particular patient. Then it goes into the various examination, their interpersonal communication skill, where you're looking at their holistic ability. This also can be used in a case presentation format where you can actually look at how they are looking at the whole area of it. Just in a very simplified form, the mini CEX is something that you do when you're lazy and you don't have time to do a complete examination. It's a kind of a simplified version of it. This can be done in the clinic. This is something that possibly we routinely would do, where we ask the patient, look at a patient, and then you comment about how they've done or what they've done. We don't usually do it with a rubric, but it's a great idea to do it with a rubric, because then there is some method to the madness. DOPS is again something where you're looking at the procedures and skills. Clinical judgment, critical thinking evolves when they do case-based discussion. And you can bring in some amount of professionalism by critiquing them by getting a 360-degree feedback done. This is a video courtesy Dr. Meenakshi.
Ready.
Again, It's something to keep you awake post-lunch. I know the long walk did help us digest most of the food. But this is, as you can see, of a pupillary exam being done. Now, has that person done this exam properly? So what are they, a novice, beginner, competent, or incapable of doing it? So they're possibly a novice, because if you look at the pupillary reaction, a novice does not check, but actually they're a beginner because they did a part of the exam. So this is how the rubric adds up. So if they did not even do it, then you would have called them a novice as per this rubric. So that is where I think a little bit of a change happens in terms of the nomenclature we use and how we actually grade them. This helps us in terms of getting it done. Next, looking at the mini-CEX. This again evolves from history taking to communication to judgment and professionalism. Again, I'll show you a short video. This was something that we got shot today morning. Here, I would like you to comment on Dr. Saptagirish, who's playing the role of the evaluator, saying that is there something different that you would have
Do
done?
this 2 times a day for a week. I'll give you one antibiotic drop to use only in your right eye for the swelling. Use it 4 times a day for 1 week and then stop. For the allergy, I'll prescribe you 1 drop, and for dryness, I'll prescribe you 1 drop. Allergy drop, you have to use once only at night in both your eyes, 1 drop for 1 month. And dryness, you can use a drop which is called Lubrex, that you have to use 1 drop 4 times a day in both your eyes. So morning, afternoon, evening, night, and use it for 1 month. You can continue using it as in when you feel that your dryness is coming back, but just get a new bottle every month.
And what should be the gap between 2 drops, since you are
Keep a gap of 5. Only the coinciding drops and that antibiotic drop will be there, so you can keep a gap of 5 minutes between 2 drops. Okay?
Yes.
You can wait outside, I'll just give you a prescription.
Thank you so much.
No problem.
So as you can see, he almost fell asleep through the discussion. But apart from that, what would you have done if you were an evaluator in the room? I think that would be something interesting to ponder and look at. Yeah. So you could have asked him to paraphrase, possibly.
Yeah, because this is, looks like a patient who's educated. So you write it out or print it out, give it to the patient to hold, and then go through the drops.
Okay.
Might be easier.
Yeah. So there you've seen that just because you're sitting in the room and evaluating, maybe it's not always appropriate. It's again good as an evaluator also to hold a rubric or a paper in hand and then look at it. So this again is a very famous ophthalmic personality who did our exit evaluation for one of our oculoplasty fellows. So here what you see happening is a DOPS happening. So here we actually asked the fellow to perform a surgery in Akshay's presence, and he kind of assessed her ability, evaluated it, and also performed and gave feedback to Dr. Samia in terms of what she had done. Again, for DOPS, it can range from clinical procedures to even surgical procedures that you can actually implement it. I'm going to pass this on because we've just had a long talk about 360 feedback. This again looks at identifying competencies, strengths and weakness, and it is supposed to look at professional development. So whenever there's a 360-degree feedback, it is important for us not to get personal about it. So that is something I think we need to remember. When should all these assessments be done? It should be done pretty much through the training program, at least during the formative period, as well as a summation in the final year. The formative periodically allows you to kind of give feedback. The summative helps you in evaluating whether the person is capable of passing through that program. And it is important for this not to become something that is ad hoc or a department comes and does, but becomes an inherent part of the day-to-day clinical work itself. This does require an inherent cultural change because it will look like you're wasting time not seeing patients by doing this evaluation. But over a period of time, it does build a lot of efficiency to it. To the individual, one, they're getting feedback. The trainee knows where they're going right, what they're doing wrong. They get motivation, they get encouraged. They kind of are told that they can do much better. And it also shows progress, saying that the last assessment you did 1, 2, 3, 4. Now you've done 3 more additional tests. So it kind of allows them to understand they're doing better. For the training program, what we've noticed is it gives us evidence in terms of whether we want to take them to the next step. If you want to recruit them, if you want to move them to another program, what needs to be done. Also in trainees and difficulty, we've sent a couple of our trainees who were not able to do cataract surgery actually to Akshay to make them work on a simulator in Bombay. And we've seen this person who was struggling to put a section now be able to do about 10-15 cases a session very easily. So that this kind of a summative assessment allows you to take those decisions where there is an investment of time and money. In our experience, what we've noticed is that you may not do it in complete 100% the way it is structured, but at least the logic of all these tools can very easily be incorporated as a part of our training. It does bring some amount of seriousness. Like Akshay mentioned, these are exams, evaluation. When we tell them somebody from outside is going to take your exit exam for fellowship, suddenly there's a fear of God that comes into them and they start studying for it because they don't want to be shown in bad light to somebody outside of the system. This does allow active interaction, the fellow and the consultants, because they're periodically speaking to each other. And there is a lot of critical assessment that happens where you're pinpointing them on particular attributes. And we've seen case-based discussion especially inculcates a lot of critical thinking because they're now looking at differential diagnosis and trying to solve a puzzle. Challenges are, again, with students, it's usually just in time because this is a grade. So there is no tangible mark, so they don't feel any value. So that, again, creates a lot of problem. With assessors, our colleagues, again, either they don't have time or they say that they'll just fill something, or sometimes they take it so much to heart that they become too critical and too harsh that the student completely gets shattered and they have no idea why they're even in ophthalmology. So in conclusion, work-based assessment and any of these competency metrics helps you look at the performance in a day-to-day practice. It gives you evidence to look at how they're learning and reflect on real experiences. And it supports learning in important areas of capability. And finally, I think it makes the trainee ready for the big bad world. Because one, they walk out with confidence about their competency, and they build a mentor-mentee relationship. Like Padma Malini ma'am said, they will send a WhatsApp message saying, this is the case, I'm stuck, what do I do? So they have that confidence that there's a shoulder that they can lean on for the rest of their life. So thank you so much, ma'am, for making me part of this session.
Thank you so much, Kaushik. That was, brilliant. Now, hereafter, I know who to request for talks in the last minute. Dr. Prashant has to leave to catch a flight, so we just thought we could quickly have a group photograph of all of us together on the stage. The sessions are not over, so please assemble here. Let's do a quick photograph.
See, photo is like national anthem.
Everybody, please, participants also, please come. Please come. Come. Somebody stand at the back. And who's stand at the back? Yep. Registered for today's session. You have the certificates ready, so please collect it at the end of the day's program. And next off, we have Akshay. And very excited to hear him speak on Oscars.
Just happened day before yesterday. आ रहा है? नहीं आ रहा। नहीं आ रहा। Purva, can I borrow your connector if you have? No, अभी चल गया. It's okay. Okay. All right. So thank you for the opportunity to speak here. And again, I'd like to thank Dr. Meenakshi for the invitation and as well as a lot of the inputs and direction in creating this talk. We've completed bits and pieces of assessing the trainee at the workplace. We've even spoken about assessing the trainers. But I think as surgeons, we need to understand that our specialty and what we do essentially, a bulk of it is in the OR. And we have to be at least, have to be able to get our trainees to reach a certain level of comfort and competence in the most basic ophthalmic procedures before they graduate. And that is why we have this entire concept of the Oscar, and I'll go over these points, which is the need to assess objectively. Because now, say for example, this is a recurring diagram that you'll see in my talk. When we talk about optimizing resources, say for example in the OR, we are going to figure out who are the trainees who are going to operate for the day. We'll control the processes in terms of which senior resident will get which complicated case and which junior does the simple surgeries. We'll watch how they operate, give them the feedback, assess their results, and as they improve in their surgical skills, that will help us optimize resources even better, because now we can allot more complicated cases to those residents, etc. So at the heart of all of this remains patient safety. And this is why the moment we see a trainee who is operating, it's important to give them immediate feedback, because the moment we see them operate, we see them doing certain things which may or may not be right. It's important to give them immediate feedback, because recent memory or correction of recent actions have the highest retention. Now, you don't want to go and tell them, last week I had seen you operate the 3rd case out of a list of 5. In that you did that. You probably barely remember it, so that resident is not going to. And you have to give the good and the bad feedback, and always perhaps preface the bad feedback with a little bit of good feedback. You can sandwich it, because feedback is the cornerstone of this entire process. And I said this in the morning, and this is a line that I borrowed from Dr. Meenakshi's presentation, which is, we cannot expect someone to do exactly what we want unless we tell them exactly what we expect. So when we give this feedback, how is it going to actually matter to them? Because we need to know what is it that we have to convey to them. How we came to the level or our judgment that their competence was achieved or not achieved, explain that to them, and describe the process of how we reached there. If we tell them that this was a very good capsular excess, we need to tell them why we think it was a good capsular excess or why it was a bad capsular excess and why they need to improve on that. And how do we come to this? Dr. Kaushik said a very wonderful thing. Not all great clinicians may be great teachers, and not all great teachers may be great clinicians. So we tell them, we ask them, a trainee, a trainer or a teacher, they may not be able to explain why a trainee is not performing well. And to help them is why we need a structured rubric. And that is where Oscar comes in. So a rubric is essentially a guideline. And in this case, it's an explicit set of criteria that we use to assess any particular surgery or performance. And these are the 3 pillars. The dimensions that are described in it, which means what are the steps that we are going to assess. The levels of competence or how well they are doing, which are graduated from a novice to an expert, how well they are doing that step, and descriptors. What is it that defines why they are a novice or an expert? And there are these rubrics for every different surgery now available. And I'm going to pull up the one that is most commonly used for cataract surgery, which is for phaco. So if you look at all of this, now let me just pull up the first 2 topics. draping and incision and paracentesis. So here, let me pull up the 3 dimensions. So now here, these are the steps of the procedure on our left side. These are the levels of graduation of how good or bad they are. You have the columns, which is novice, beginner, advanced beginner, competent, and what is it that makes them a novice? So the descriptors. So you've got all 3 parameters, or all 3 tick boxes in this, and if you give this adequate granularity, which is right from the first step of draping right till the end, then you have given, you're able to understand and assess the trainee across every step and sub-step in that surgery. So a structured rubric gives you this advantage. And this is the ophthalmology surgical competency assessment rubric called the OSCAR, which is standardized and internationally validated on different surgeries. It's got different, it's got behavioral and skills-based rubric, which tells you if a surgeon is doing something right, what makes them go into which category. Also, when a surgeon is doing something wrong, why they are falling back into a beginner or a novice category. The single most important part of this rubric is it is objective, which means that interpersonal or inter-observer variability is less. It does not allow the surgeon to like or dislike or put a personal preference, because they are giving you a very clear criteria of how to judge and score the trainee. And also at the end of the day, especially if a trainer is assessing the trainee with the OSCAR rubric in their hands while they assess or observe, along with the surgical video, the paper or the feedback or the form that they fill up goes to the resident, and they can actually see where they fell behind and use that as self-learning or self-improvement tools. So the goals of OSCAR was precisely this, is to create reliable, reproducible, valid surgical skill assessment. And they basically, the stages of competence based on which the trainee is divided is the Dreyfus model, which is either a novice, a beginner, an advanced beginner. And an expert is not something that we'd expect a trainee. Every trainee at the end of residency may not reach that stage. Well, some of us are still not experts in our own specialty or subspecialty. So this is the reason why we created the OSCAR and why it works. Now, to understand the role of the OSCAR is at the end of, I'm repeating myself and a lot of the other previous speakers, is to measure the results, to assess how they are improving, and to document how they were doing. And entirely, in some way, the OSCAR is also based on the TOE model, which is you grade or score the technique, you grade and score the outcomes, and also you observe the errors that the trainee makes. And all of these, along with their behavioral, cognitive behavior during the procedure, helps you score the trainee. There are OSCARs available for different cataract surgeries, for small incision cataract surgery, phaco, extra cap, strabismus, lateral tarsal strip, there's external DCR, there's anterior approach ptosis surgery, trabeculectomy, and panretinal photocoagulation. This is just a few of them. There are a few more as well, all of which are now available on the OF website. Some of them have transitioned from the ICO to the OF, so it's also on the ICO website if you're interested. And finally, how do you effectively use these? So now we know, why do we need to assess objectively, what are we going to do with the OSCAR, and why did we come up with the OSCAR, and now we need to see. Now the OSCAR, apart from those steps and the gradation of the trainee, there is something additionally in this called global indices. Global indices is a very a behavioral assessment, and it's generic terms, I'd say, but at the same time specific in their outcomes. Now, if you look at global indices, this is what it is. So you've got things like maintaining hemostasis, tissue handling, knowledge of instruments, technique of holding suture. So a trainee may actually be able to get one single suture right, but in spite of holding the needle in a wrong way. So we are not just grading the actual act of taking a suture or how the suture came out, but how the trainee performed in holding the suture, passing it through the sclera or the cornea, and how they tied the knots. So the trainee, trainer is also expected to assess global indices, which goes as a part of the Oscar. So I'm going to do a short exercise there. I'll run this video. This is just one step of making an entry into the eye for a phaco. And we'll try to see what the audience feels or where they would grade this trainee. You can see he's a little tentative, so he's definitely a trainee. This is courtesy one of the videos from Dr. Uday Devgan's huge cache of surgery videos. All right, so he or she has made a decent corneal entry. Now, we're not expected to know the entire table by heart in our head. So you can actually carry it on your iPad if you are Pranesh, or on a piece of paper if you're one of us. But the point is to have it ready with you. And there's absolutely no shame in having that while you're assessing, because these are things, you're not going to, it has got so many steps on so many levels. It may not actually be feasible to go back and to think of how the surgeon was doing the surgery and then retrospectively grade it. So have it next to you. So now this is your incision and paracentesis. Let's just look at incision. How many of you all think this was score 2 for a novice? A show of hands. How about a beginner? Score 3. Advanced beginner. 4. The incision was well placed. Okay, we don't know if it was non-leaking yet. Or a competent surgeon. So none of you are assessing. What would you assess? 4 or 3? 4? All right. So let us look at the video again, and based off of what was actually, so this is actually a surgical video which was submitted by a trainee called My First Clear Corneal Phaco. And based on the commentary that Ujay Devgan has given, and also the point markings that he did later on, we're looking at a couple of things. Now look at how the trainee is grasping the conjunctiva and what happens at that site. There's a subconjunctival hemorrhage. Now here the trainee is a little tentative, makes an initial incision, then again goes back in. Now it's traveling too shallow, hugging the roof almost, and makes an abrupt indent downwards, creating that dimple. And there's a very abrupt jerk-like entry into it. What the trainees actually ended up creating is something like this, which is known as the chevron appearance. And what that happens when you have a shallow roof to your tunnel, a sudden abrupt cliff-like entry, which is suggestive of a very poor form. So this would actually push you back into probably a beginner or a novice. And again, you need to, when you look at the global indices, you would end up saying that patient was not, the tissue handling could have been a little better. So let's try scoring this rexus now. Same surgeon, same case. You can see how much that subconscious hemorrhage is now increased. So you're creating the initial incision. The trainee is able to grasp well and re-grasp at the right side. Now, the trainee could have grasped it closer to the uncut edge, struggles a little bit, and now when he decides to grasp a little closer, he's able to do that and has managed to create a capsular rexus. Now again, it's not at the tip of our fingers. We go back and look at it. Capsular rexus, commencement and formation. So first thing is the size and position are adequate for the kind of nucleus. Inadequate, all right. So that would then put the trainee directly in the novice. Barely adequate, so it has multiple steps, multiple parameters by which we can grade. And you're right, let's look at the actual rexus, how it went. So this is not a well-centered or an adequate nucleus for adequate rexus for this nucleus. So that is why you would be able to grade it very objectively using the descriptive parameters in them. Excuse me. So at the end of the day, the Oscars are here to help us make objective assessments, which are reproducible assessments. It helps the assessor with specific examples of what to use as a guideline while scoring or assessing trainees. Tells the student what is expected of him at that level of training. Helps identify specific areas where they need special guidance or improvement. And it gives us the opportunity to provide a structured feedback, not to, for the trainer to provide a feedback in a structured form to the trainee, because sometimes the trainee may feel, oh, that the academic dean doesn't like me, or this consultant doesn't like me. Well, at the end of the day, it's not personal preference or not. You have a structured feedback that tells you that, no, we are upset at you because you need to improve, and not because we don't like you or dislike you. So it gives you method to the madness, if I may say it. So thank you, and I think we can move to the next talk.
How many of you here have incorporated the Oscars into your... oh, that's a great, good show of hands.
Yeah.
Thank you.
So just a quick thing. So the Oscars have actually now expanded even into simulation. So there's a validated tool called the Oscar, which allows you to assess the performance of a trainee on a surgical simulator, and different simulators. You have the Fidelis, you have the IC, and the Help Me See simulators. There are papers where all three of them have validated the Oscar, which was, I think, initially formulated by Will Dean and his colleagues. Yeah.
Yeah. How often do you incorporate the Oscar?
We did that for the first 20 cases. And then is at that point, then you actually see a plateauing. And that tells you. But the first 10 cases are crucial in helping you identify where is it that this particular trainee is screwing up. Especially, so what we saw was cases 1 to 5 were the SICS tunnel depth. Premature entry was the most common. 7 to 12 was when they would struggle with a rhexis. And I think case 22, 23 is where they were a little more consistent in their scores.
I think you could also identify the steps that they struggle with consistently. And you don't have to, you may be a busy rotating supervising surgeon. You may not have time to do an entire Oscar. So you could just come in for those steps to see if those have improved.
As part of my advanced course in medical education, I did a project on Oscars. So where we made them record their own videos, and then we asked them to score themselves. And the faculty who was observing also scored. So we had a comparison of the results between the second years as well as the third years. So in that we have two aspects. Not only the faculty scored, but they themselves saw the videos and they also gave the scores probably. And then one more feedback was there after the surgery was over when they scored. So we had a comparison like what I scored and what the resident scored. So that also we actually...
So what was the...
there was actually what happened was between second and third years. The third years, obviously, because of number of cases by the final year, they would have done more when compared to the second year. So that was, their scoring was good. I mean, their feedback for themselves. And not much of a difference between the faculty and the student feedback.
Okay.
But in the second years, obviously the difference between the second and the third year was significant because of the number of cases what they did. And the faculty who scored also. That the same kind of a difference, the difference between faculty and the student scoring was much more in
All right. So the agreement was greater for final years and lesser for second years amongst self-reported scoring and faculty scoring. So that's very interesting. Trainees felt they were not as good as the faculty thought they were, or did the trainees rate themselves higher?
The scoring was much more, I mean, it was similar. The faculty, the particular step, whatever the trainees thought that probably a 2 or a 3, even the faculty had given the same score. Okay. More or less in some steps, probably hydrodissection or tissue handling, the global indices where the trainees thought that they managed the tissue very well, but that was not the case from the faculty. That was the major difference.
Interesting. Thank you.
Move on to the last talk, the last didactic talk, after which we have, finally, after all the assessment and everything is done, we're going to have to give feedback. And that's exactly what Dr. Helena is going to be talking about, feedback time. Following this, we're going to present 2 cases because we have to take all the learnings and go back to our trainees. So even those of you who have not registered earlier but are attending, please collect the certificates as well. Thank you.
Thank you again for sticking with us in this adventure, this journey on medical education. So it's feedback time. I think my presentation is already presented, is already done with the previous marvelous lectures that we have been listening to. So if we go to feedback, feedback can be defined as kind of a regulatory mechanism where the effort of an action is fed back so that it can be modified. But the idea of this modification is always for improvement, for improving the future action. So the goal of this presentation is to be able or more able to create a culture of feedback and articulate the concept of underlying feedback with the learning environment culture, explaining challenges in giving feedback and engaging learners to change their practice. So making learners welcoming their feedback and describing 2-3 feedback structured models. My presentation is alive, as you can see. So we will focus on the concept models and guidelines. And where is feedback in the assessment cycle? Feedback is, we can divide assessment in 3 great moments. Before the learning experience, during the learning experience, and after the learning experience. Before is when we think about diagnostic assessment. During is when we provide feedback. And after is when we assess in terms of summative assessment. And this can be designed, I don't know what's happening in my presentation, I'm sorry. I'm not clicking in any button, it just moves by itself. Diagnostic, if it's before. Formative, as we saw earlier, if it's during, it's given during the learning experience, and afterwards as the summative, which is very useful as well. And also the diagnostic step that provides us with an information of the needs assessment and defines our group of learners. When we think about feedback, we are thinking about assessment for learning. And when we think about summative assessment, we are thinking about assessment of learning. So this presentation is mostly focused on assessment for learning. Feedback should be based on multiple sources of data in evidence, as we have seen today in the presentation that focused on the multi-source tool for assessment. It's a process that involves skillful interaction, and we will see in a minute how we can, base our model of thinking when providing feedback. Should be timely and frequent, should be at the workplace, should be workplace-based, as we also have seen this morning and the afternoon. Should be constructive, should be coupled with some plan for the future to improve those areas that were acknowledged both by the facilitator or the mentor and the mentee or the trainee. Should be welcomed by the learner, otherwise it won't be any use of it. And somehow I can connect this with presentation of the challenging case this morning. And should be tailored to the learner development needs and preferences. So feedback is very specific for each of us because we are all different and should be tailored for our needs, specific needs of the learner in a specific context, and should be reciprocal. So the mentor should be someone who is trusted as more experienced in some area of knowledge or skills or competence, but also should be able to receive feedback from the trainee. So if evaluation is summative, should be scheduled, formal, based on past performance, should be usually is linked with some kind of giving a certification and grading the person, the trainee, saying that he or she is able to move on to the next step. It's usually a monologue and it's based on global performance. Feedback is formative, is for learning. It's not about assessing learning, but assessing for learning. Immediate, timely, at the workplace base, should be informal, should be based on what is happening at the moment, should foster learning, so it's for learning. It should be also a dialogue. As we can see, there are several models that we can, have in our minds, the one that we would like most to develop and provide feedback, and should be very specific. Usually, feedback is based on teachers appraising performance and providing this appraisal data, and learners should improve their performance based on that information. But somehow, and mobility has also propelled this new lens that we should take into consideration when we are thinking about feedback. There is the social cultural lens where the learner's improvement is at the center, and there are several specific and different aspects on the recipient, the person, the trainee that receives feedback, the provider, and also the overall cultural lens that embodies, for instance, the culture of the organization where we work with. How can we give feedback? And these are several models that we can choose what we like best to apply. But I would say that the main message here is to create a relationship with the trainees, and let also the trainees create that relationship with the mentors or tutors or coach. It's a little bit different. Coaching generally is associated to a specific attainment of a specific outcomes, and then the relationship usually stops there, just like a coach in football. And mentorship is a little bit wider in terms of relationship. It usually involves a little bit blurring in terms of the outcomes, but what is mostly the flame of the relationship is that both the mentor and the mentee can grow as persons and professionals as well. So this is a very classic model, the model of the sandwich, which we start by asking, how did you think you go? All these models are based in a conversation that should be taken place very close where the action took place. It can be ideally in a quiet place after the action has taken place, but immediately after, so that it can be timely. And then tell the person that, well, I saw that you were a little bit not so confident when you were doing the capsulorhexis, for instance. And then what do you think you could do the next time? How can I help in this? So this is kind of the two parts of the bread, asking and then giving the meat or the great filling of the sandwich in the middle, saying that, well, I saw that you did this right, but I also noticed that you had some kind of, it struck me, some kind of a difficulty in this part. What do you think we could do for this to be more self-confident about this? This can be done very expertly, but I would say it also can be done very technically. And the person who's receiving feedback knows, oh, this is the plus. I'm just waiting for the, rainfall to come the next time. And then, oh, what happened? So this is to say that the ideal relationship is where the mentee and the mentor, when they are in this moment of feedback, they have this trust that this is a moment of discovery for the mentee, and the mentor is there, hopefully also to point out areas that could be improved for the sake of the development of the mentee. Mentors that say that, oh, that's okay, you don't need to do anything more, it's fine, you're doing fine. The mentee, if he's, demanding about her profession or his profession, would say, well, I didn't feel so much about this or that. So there has to be a relationship of trust here. This is another model. This is the R2C2. Let's see what this stands for. It's building rapport, building the relationship first. This is the landscape of every good feedback. and then explore the reactions. This is kind of the first layer of the sandwich. That is, what do you think it happened? How did you feel it go? And then go on and with the conversation and see what the mentee says. And then for the end, the last C, so the first R for report, second reaction, R2, C2 for content, and then the change. This is very important. There's something to point about that can be improved. Other areas were excellent, but we have a plan for the future. Suppose that everything went right. Okay, but the model still applies. We must have a plan for the future. This is perfect. You don't need to worry more about this. But what would you do? What would you like to do next as a move on? The advocacy inquiry approach is something that we spoke about in this session, and it's about exploring how, and I would link this again to the first challenging case that we have this morning, understanding I think the second one, sorry, exploring the values, the culture that the trainee has that make him or her react in a certain way. And these frames would be kind of the construction, the building of the person, making this or that option or this or that behavior, the actions that led to these results that were perfect or not so perfect. And this would feed back exactly to improve better. And this is the so-called advocacy that is based on observation. I saw that you weren't so confident about doing the capsule rexes. And here is the good judgment. There are the indifferent judgment, the bad judgment that is completely to avoid and to, just say you did the terrible work. I don't know how you came here. This is completely to avoid. And you can be either as neutral, judging, or good judgment. And these people who stand for this model say that you should lead your mentee in the good way, and say that I think that if you had, for instance, a little bit your anterior chamber with more viscoelastic, it would be easier for you to complete your rexes. I am curious, and this is the inquiry, why you didn't do that? An example. And this is the GROW model. This is something that came from someone who was in the world of business, then went for the racing cars. But see what he says. We must see people in terms of their future potential. And this is something that as mentors, as coaches, as educators, as teachers, we should see in those whom we would like to help improve. And this is the GROW model says, what do you want? And make the person reflect, what do I want? What is my goal? What is my reality? What is my landscape right now within my goals? What options do I have to attain my goals? And okay, what's my plan to attain my goals? This is the model. And this is the last model, but there are many other models. And this is something very specific to link with the coach. And for instance, we can be coaches, for instance, and sometimes this happens in organizations. The trainees have the mentor, but they have their senior colleague who would be some kind of a coach for a specific training of a surgery, for instance. And the outcome there is to do that surgery as best as the trainee can. Report, again, relationship, expectations very clearly explain about the task that it's done, observe, conversation, and documentation. How can we create a culture of improvement and feedback? 12 tips. On the side of the provider, on the side of the mentor, create this positive learning climate, be a professional role model. And we know, we hear about very much about being role models, and we all know that we ourselves as role models depend on the context. If we are hungry, if we are in a hurry, we aren't always the perfect role models, and we must think about that, and sometimes that can come up in a conversation with our mentees. Observe performance and facilitate reflection of the learner, but be there to facilitate that reflection, that self-assessment. Don't leave the mentee just by him or herself. Sorry. And this goes. Then on the side of the mentee, foster growth mindset. Say that we cannot control everything. We have to be adaptive. We have to look at our failures as also opportunities to be better. Not at the OR, start at the simulation-based center and be protective of the patient as best as we can, but also take this kind of approach so that the trainee can be self-confident. And then the relationship is very, very important for feedback. Whatever model that we have, it's the scaffold of every successful feedback. Create these alliances between the teachers and learners. We are allies for your improvement. And also, if I'm the mentor, for my improvement as well, because it's my success. If I can see success in my mentees and say that that is the school of my organization out there, that's their school, it's here. So it's a kind of to be proud of. And also, for the organization, every organization has a special context, has a special hidden culture, and we have to take that into account when we are working in that specific context. So we have here some items, so balance, supervision, and autonomy. So be attentive, but at the same time simultaneously leave some autonomy, some space for the learner to have their space for development, create this continuing practice improvement environment, and foster this feedback culture. Okay, let's talk. We are not superheroes every time, but if we talk each other, we can find most certainly a way to the future in terms of improvement of yourself, of your actions, and also to me as mentee. So relationships at the center, effective feedback, being embraced by the learner as means to develop professional growth, not taken as something that is diminishing or taking self-confidence, on the contrary, and also being provided in a safe environment, create this relation of trust that should be timely, frequently, always ending with a plan for the future, constructive, and celebrate achievements and plan for the future improvement. Trust, dialogue. I cannot teach anybody anything. I can only make our learners and ourselves in general think. And this is our job main job as facilitators. Thank you. And thank you. My presentation has completely come alive by itself.
Thank you so much, Dr. Helena. Anybody wants to share anything special that you do or different that you do when you give feedback to your trainees? And while you're thinking about it, we will move on to the last two presentations. I invite Dr. Soumya to present a problem resident.
Good afternoon, good evening everyone, and I thank Dr. Meenakshi ma'am for this opportunity. So I'll be presenting three aspects of a trainee's life. So where we can really know whether our trainee is on track or anything else to be needed. So those could be in the academics, in the clinical or surgical skills and in the field of research. So I'm just presenting case scenarios, and probably I would be asking our esteemed panel that how, if really we could, or we could really solve these problems or make our trainees on track. Now, a final year resident doing a seminar on a topic which was given probably 6 weeks earlier. On the day, the seminar just comprised of very superficial information from not so authentic resources. Now, this has happened a couple of times, and the resident was strictly asked to correct it. So this has happened many times, and a topic which really requires a lot of reading. Probably, if we remember from our days when a seminar topic was given, probably 2 months before, we just used to refer to all the textbooks and make notes, including the applied aspects, the physiology, the basic sciences. But then probably we see our trainees, and not in the mind actually criticizing them, but probably 15 or a week from now or a week before, they'll start preparing on the topic, they'll get the information and present it as a seminar. So really not so holistic approach about the subject. So probably how we could really make our trainee on track. So the one thing could be, we can just tell them that, now what were our efforts is, could be verified online resources. So we just provide them some online resources which are verified, like some known websites from which they could take the information, and also the authentic textbooks and monograms, which are excellent resources. That's very, I think in survey of ophthalmology, when it was really available, a lot of monographs, really review articles which could explain detailed about a particular subject, and also not only just looking at the topic, but including some applied aspects and basic physiology, pathology, pharmacology, as well as advances. So not only that clinically they are well equipped, but also to write an exam, to write a long question in their exams. So that also would help. And copy-paste attitude to be really stopped, because if they could read, if they could write on their own, that's definitely helpful for them even while writing their exams. And moderation from our side, pre-preparation of the seminar topic and showing it to a person who is the in-charge moderator could definitely help them probably correct their presentations and present it in a very good manner. I just expect any other inputs on this topic.
When Akshay was a resident a long time ago, I'm sorry, it was maybe many 10 plus years ago, they would get extra iodination calls and have surgical privileges cut off. But I don't know anymore. How would you tackle something like this? Any thoughts?
I think, like you said, moderation from our side. So one of the things that one way that you'd get that time get it done was to assign a faculty member to essentially, to preview the presentation and approve of its contents a week beforehand. So that way it is done, and over if it's a well-oiled residency system, the moderators themselves, their reputation would precede themselves, and at least on this task, if they are particularly stern, word goes around quickly, and then they know that they have to show up and get the approved presentation a week or 5 days beforehand, and then it, that way, that is one way of streamlining it. The names I'm thinking of, so.
Probably making it a routine, a pattern kind of a thing, that that somebody is going to check your presentations. Yes, yeah.
Roster. Yes.
Yes, yes. Correct.
And that's like a badge of shame. So
Yeah.
that doesn't go down well with them.
Probably a senior or a peer, because I was thinking that for some residents this can be a nuisance, and they can be expert surgeons and wonderful clinicians, but they don't like so much the academia part of it. Can be not so much theoretical, and probably having the assistance, cooperation of their peers. Sometimes it for some, especially if they have peers that can be a little bit more, expedite in terms of setting this forward. But it can also be something that can even stimulate someone who is not so keen on the theoretical part of it be a little bit more confident and more expert on that.
We use, in fact, our roster used to be the resident will present the case, the fellow will do the discussion, and then there'll be a moderator who will do the comments.
I agree with Dr. Helena, ma'am. And like, suppose I get a topic to present, and but I'm stressed about presentation, like how to put the slides. Like PowerPoint, making PowerPoint itself is a very new task that the person is learning, that the resident is doing for the first time probably in his life. And at this point of time, the peers or the seniors, when they go all sit in the library and read up the material and, okay, you put this, after this you do this. So that really helps, especially in the first few presentations, till the resident gets a hang of how to present a presentation. So,
Okay, thank you. Yes, ma'am. Another busy OT day. It's a camp OT where the final year resident student operated a mature cataract. It was now the turn of a second year resident. Next to him, a faculty was operating with a JEST microscope. The final year resident who operated first is busy outside the OR with mobile phones. He does not want to observe the consultant operating nor see his junior do the steps. He was told a couple of times previously too that he needs to observe cases repeatedly so that he can rectify his mistakes. So again, this is a common scenario where we also see this. So probably what we, or what the best could be done is we can ask one of the seniors to finish this OT and then operate or then monitor the junior resident who's, second year who's operating. So probably can also say that at whatever particular difficulty he has, he needs to pitch in first, followed by the consultant who would do that. But then this has been going on. We have told these n number of times, but this also, it just crops up. So probably, I don't know, the repeatability and okay, I know this, I know how to operate a cataract, so it's fine. I know I can operate everything, whatever I get on my platter. So that's also one thing. I mean, every time we say that each case is unique, each case is different. How you approach. That's also a very common this one. So, ma'am.
So again, the hook is going to be the key. Even for the previous case scenario, the hook is exams. Yes. So in my institute, my academic director is the internal examiner. So if you don't present that well, you know that you're in trouble. The same with this. If that final resident is not going to do that, no surgical cases. So, cut the OT turn. That's going to be. It's going to be a harsh thing, but that's how.
But one more thing could be a kind of a portfolio where after you operate one case, if you could just write down what all mistakes you did in the previous case and whether in this case what particular step which you had, something like an Oscar where we did a self-feedback. Similarly, if you could jot down what are all the problems we did in the cases. So probably in the next time, if you anticipate that the way you are doing, putting the incision or the way you are entering, every time repeatable steps, you're doing it bad. Probably do it a different way or approach a person who is doing it very nicely. So we could adapt at that particular step.
That's a good way. So reflective journaling is a very good tool. You can use Google Docs for the same. But it only works if you, as the mentor or teacher, has actually looked at the reflection. Otherwise, they never know whether they're on the right track or not. So it's a great tool, but only with supervision. But yeah, it works.
I was thinking about, the hook and the external hook and the internal hook. And I was struggling a little bit about that idea in terms of the motivations, our internal motivations and external motivations. And something that I think external motivations are very, very powerful. Examinations and assessment drives learning, right? But what I would like to find is some pathway that could, and I also pointed out in the presentation, a social cultural lens. But it doesn't mean that it's so much different in terms of geography, but to know what moves that trainee, what moves that fellow, what is to create that relationship so that we can bring up those internal motivations, because we always have external motivations, but if we do that as an internal, if we have an internal drive to keep our lifelong learning journey as professionals, as persons as well, but as professionals. I think that will be much easier and much enjoyable life in the future. And that will, I think that will, you know, shine around that way of being in life. So if we could make our mentees discovering that inner drives that make them learn, okay, with external motivation, but more important than that, they would face the external motivation more confidently and probably with higher marks. I don't know. But anyway, this is just an opinion. Thank you.
Thank you, ma'am. And moving to the research part, it was a busy OPD day at the hospital. A patient who was on topiramate had developed drug-induced glaucoma. So we had collected similar cases over a period of time, which would be published as an original article. The faculty offered to help in whatever way she could pull up to a publication out of this data. The faculty was on leave for a month and she had asked the resident to mail her the manuscript. Even after the faculty came back, the trainee did not show any signs of having started to write the manuscript, in spite of telling that this is a mandatory requirement according to the NMC. So the responsibility is research. The questions would be, is research useful for my career? Research anxiety, difficult to do, fear of paper getting rejected, and I do not have any interest in research. Now, that's what. So this is the major concern, I guess. So even though NMC has mandated that it has to be accepted for publication or it has to be published. So that's one of the requirements now for postgraduates. Now in this again, we would have seen many interesting cases in our daily OPD. So alarming number of patients are more. So we would want to give them the treatment and go back. So in that particular thing, we had case series of such cases. And then definitely more than 5 or 6, which can be an original article by itself. Now, that is again one area where we need to address.
Not just the trainees, I think this is each of these 5 are applicable for the trainers.
Probably is everyone on track, I guess. I don't know.
Problem trainer, problem trainee. So this is going to need any comments on this? Yeah. Yeah.
Yeah, that's what she was.
In terms of the type of the article, the type of thank you, the type of the journal that will be more, and also to help with the feeling that, as you said, this is the same, we are under the same sky, and it's difficult, it's hard, but when it happens, it's so exciting to see it published. So it is worthwhile to endure and to be resilient. I think these can be what the mentors can do in this type of cases. There are others who wouldn't like at all to do this, but I think that with peer support, it happens to be a little bit easier. Peer support is very powerful because this new generation are very gregarious and they are very helpful among each other, and so I think it's very useful on
I guess
that
the positive
side
reinforcement that happens after a successful publication, I think says it all. Probably if they get into that groove, I guess.
Yeah. But be prepared for the, difficult, If you're rejected, it's no big deal. We are still alive. We are still here to fight.
Yes.
So, a couple of things. So at one of the places where I am an honorary, where we have residents, since 2019, now it is 2017, it is now mandatory, at least in the MUHS, Maharashtra University, that every resident needs to present a paper or a poster at a state or a national conference and be, an NMC requirement. Yeah. No, but some of these are deemed universities, so they get to do their own things. But so having made it that way, a lot, what the city has, the city, Bombay Ophthalmic Association has done, taken up is organize a research seminar for all residents joining the ophthalmology course for all the medical schools in the city, and make it part of their annual conference on day 0, like this, a pre. So these things could help them in helping them. Also, there are a lot of wonderful online courses. You've got Sunny Sengupta running his research academy. So there are a lot of external sources that they can rely on, especially now that this is made a structured part of their residency, one of the prerequisites towards completion. we should also need to think out of the box and make it a prerequisite part of our planning for residents.
A lot of resources to help them out too. Thank you so much. Thank you, ma'am. Thank you for.
Thank you, Dr. Soumya. For the last case, Dr. Akshay will be presenting. I want to again encourage all educators to please go to the Ophthalmology Foundation's website, which is OFECC, Ophthalmology Foundation Education Consortium campus, and look at the 21 teaching skills for ophthalmic educators. There are 21 modules, and you get a certificate for completing each module separately. And a lot of ground that we covered today can be found there, and they're very useful. Please pass this on to your colleagues as well, because a lot of work has gone into creating the modules, and a lot of speakers today here participated in the modules. And if you have any good ideas for modules for educators, please do write to us, and we can start working on them together.
All right. Thanks. So I'm going to present my problem trainee case, and hopefully this is a problem that I experienced as a resident, sometimes seeing a couple of other residents, and also seeing now it comes back to haunt me as a trainer. So this is my resident who's a 25-year-old male, no current resident though, let me clarify that. So a 25-year-old resident who at this time was in their second year of residency, a relatively obscure, uneventful first year of residency, and they've now just begun active surgical steps and complete surgeries. And in the middle of this training program, for a 1-week period, he goes missing, switched off, untraceable, uncontactable. He lives off campus, so there was no way we could have sent someone to their, to their hostel or something. He's absent during duty hours in the wards or in the clinic. I think the first time this happened, his co-residents covered up for him and tried to, say things like he's unwell, etc., etc. And whenever there was any we attempted to reach out to him, senior residents, professors, even the chair, there was absolutely no response. But miraculously, 6 days later, he's back. His excuse was he was unwell and he needed time to recover. The department even contemplated informing the dean or law and order services to see if he was really missing, because he lives off campus and there was no way to physically get him on track. And when we tried to do the 360-degree kind of information or background check, in the clinic he is good with his history-taking, examination techniques. In fact, in the OR, he's a little better than some of his peers and co-residents. His paperwork does leave a lot to be desired, and he's lagging behind severely on his thesis and his dissertation. His thesis guide is a first-time guide, a type A personality, is more worried than the student, more anxious than him. And he almost seems to be taking advantage, knowing that this is a first-time thesis guide. The thesis is going to write itself and she'll do it for me, kind of. See a lot of heads nodding in agreement. Then again, there is a relapse, a second episode, 4 days, missing, incognito. Back again, with no remorse, no. We spoke to his legal guardian, is one of the names listed when they enroll. Not taken seriously. So, are we missing something? Because, obviously we are missing something, but what is it that we can do? So is it a problem resident or is it a resident problem? So how do we correct this no fear for the consequences kind of an attitude? One of the actions or punitive things that we can use is to let them know that you're not going to be able to complete your university, your board exams. You'll not appear for the exams or give your final theory exam. But the medical school, the medical college and the university has a very lenient approach, which is documented on paper and said you cannot fail behind a student and make them not appear for their final examination, so that sword on their, hanging over their heads is also no longer there. Do we escalate it to their parents, their significant other, or something of that sort? what is the punishment, or if no punishment, how do we counsel? And more importantly, how do we handle the thesis guidance? Lot of questions, lot of problems. So, I mean, you've been the academic director for almost a decade.
For those of you who need the actual story, contact me outside. I can't say it in
Like I told you, when you asked me this case, I didn't even have to go far off.
Yeah. This resident was responsible for 90% of my grey hair. Any comments?
It wasn't me, please.
Any comments? How do you, I mean, a resident who seems to be otherwise okay, but is just missing without any excuse, no remorse, uncontactable. What do you do? I'm sure there are, everybody's looking at me like I had the blessing of having such a resident.
So like I said, now it's come back to haunt me again.
There's something very serious. The first thing that comes to mind is some drug addiction or something.
Some personal issues also, I guess.
Yeah, I mean, it could be one of the things that we need to look at is that.
Incognito like this, it looks like
a system of counseling in our college. So if students or residents go unnoticed like this, not unnoticed, but without any response. So we have a psychiatric department, and we send these students to them. And most of them come back after psychiatric evaluation, they come back with some psychiatric problem. And they are started on treatments. And they have improved, actually.
So actually the first time it happened, we tried to figure out where the trainee was the previous day. Did some faculty member, react impulsively, say something that shouldn't have said, cause something to upset or snap them, and introspect and see, was it us that did something that led to this? So, the first couple of days, the first day was maybe he's absent or not gone. The second and third day, we had to do this introspection, collective introspection, to see if we missed something. And that's when we realized, okay, maybe it's not us, it's them.
I think punishment won't work at all. Yeah. I mean, that's just ruled out, doesn't really... Probably, like what you said, sir, the tracking of events, what happened the day before, the first time when he was not there, I think that would... probably some personal issues also, I guess, like what madam was saying, that's also a
so
Department of Psychiatry.
How justified are we in trying to...
no, I agree that we cannot... but if it is affecting his professional career, or if it is not allowing him to progress further, I mean, which is going to be a bad thing for him or her. So I think as a mentor, not going to too much of details, probably we can just elevate his, that's what I think.
And part of me believes that there is definitely some factor. You did mention in your 360-degree analysis that research was not something that this particular resident was interested in. Mm-hmm. So there is a part of me which believes that he's probably not even interested in this subject. He might be good at it. Yeah. But he's not interested in it. Because if I were to be interested in something, I would show up every day, 10 minutes ahead of my time. But if at all they're not interested, they might be just looking for something else. And if they're not available, that's just a part of, a lack of professionalism, which reflects in the fact that they're not interested.
You actually touched upon the truth. A lot of other things transpired before the resident kind of came around. But yes, there must have been a very big element of disinterest. Mm-hmm. I want to talk about familial or generational or congenital ophthalmologists, including myself, where some of us are just born into ophthalmology families, and you just have to, you sort of are coaxed or threatened into following that. And so in Shankaranithralaya, that happened very often. We would have residents, fellows who really are not that invested in the subject at all, but are there because of family pressures. So that actually happens as well. I don't know what happened. I know the president graduated. The thesis guide ran away.
Yeah, so the resident we had 2 years ago I think our resident actually was not allowed by the university to appear for their final exams. And that resident hasn't yet approved. It's appeared for the final exams since they were due to appear in 2022. So it's been 2 years, and the resident now is actually pursuing a different career. So I think, like you said, my resident actually just vanished again, and I think the third time that they vanished, they didn't come back. So he's not completed or graduated.
Yeah.
Exactly.
I told one such resident to actually change the career, and now they're in something else.
Ma'am, in this scenario, I would say the parents would need counseling more than the resident, people who forced him to do. Okay. But then I think he should be told in no uncertain terms that you're really pushing your child in the wrong direction, might perhaps think.
Oh yeah.
Because it's a roadblock for you. What else can you do that?
This is a perfect case to illustrate that model of giving feedback. There is the advocacy and inquiry. That is based on understanding the frames of someone that justifies their actions and then leads to the results.
Right.
You know? So the key thing here would be to understand the frames of this, the internal organization of this trainee, of this resident or student, right? Student.
Yeah.
I think it's a student.
It is a resident, yes.
So if we don't get to understand that, this is an unsolved case. So it's kind of filed cases.
X-Files.
X-Files. Exactly.
Right.
It's a good case.
Thank you.